COA partners with Optometry today to bring together 3 optometrists and 1 ophthalmologist to discuss Fuchs corneal dystrophy. But to start off with, we wanted to find out what our optometrist's first memories of detecting Fuchs in practice were.
I remember my first one quite clearly because it was a recheck patient that was booked in with me in practice, and she had been complaining about the glasses which had been given to her previously. She came to me late in the day and she said, "Oh, my old glasses are much better in the evenings." And I was thinking, God, this is funny. Why does she not like her strongly myopic glasses like later on in the day? And that's sort of when I started putting 2 and 2 together and looked at the slit lamp and I was like, oh, right, this is my first Fuchs.
I think when I first qualified, I must have missed hundreds of cases, even years after, missed them because I didn't really know what I was looking for. It was only in the last 10 to 12 years, that's half my qualified life, that I think I've really looked into Fuchs and can see the signs and look out for symptoms for patients suffering it.
I don't even realise I'm looking for it. It just sort of becomes part of my slit lamp routine. And as I'm swinging through, I just kind of pick it up with like my peripheral vision.
I think for me, when I work in a corneal clinic the majority of the time, so I'll see it a lot more. We look for it ordinarily with every patient that comes to the door, whether we're doing refractive or cataracts. Or even routine eye examination, just part of our examination now.
How long do you monitor progression for?
In practice, I will manage someone to the point where I think, right, we are going to now need to have surgical intervention.
Even if you have nothing fancy, you can have a look at your slit lamp, you can describe what you're seeing, and VA will be a big clue to that as well.
I mean, I think CCT is playing a bigger role, especially with anterior seg OCT. I use that now rather than sort of the traditional pachymetry measurers that we all used to use.
So I'm really lucky. I have a pentacam in practice, so I can monitor corneal thickness. It's just a fantastic piece of kit, and it will let you do side-by-side comparison as well as slit lamp, because always checking slit lamp and patient symptoms and history. Also from a referral perspective, I do think that sometimes some of our respected colleagues in the hospital eye service, if you can show them the numbers, they're a bit more inclined to go, okay.
How much are we supposed to be doing a baseline endothelial cell count on these patients?
I would say as an ophthalmologist, I wouldn't really expect community optometrists to be doing baseline specular microscopies.
But it's the case, do we refer them for that as an initial, oh, we've seen this, let's get you referred so we have a baseline number? How do you want us to work?
What's more important is probably measurements of their visual acuity. I mean, if someone has access to a specular or anterior segment OCT, it would be good to have a baseline. But if they have normal vision and no other symptoms, and even if they have catarrh, I probably wouldn't do anything anyway.
How much do you look at quality of life?
This goes down to the patient and what the visual requirements are. Once they start to get symptoms, it usually means they're starting to decompensate. So if there is an intervention to be done, it's probably a reasonable time to do it.
Are there kind of like national guidelines?
No, I'm not aware of any national guidelines. There are some general rules. So if they've got blisters, for instance, and obviously decompensated cornea, and then that would definitely require intervention. But generally, if it's over, like for me, if they're over 600 microns and they've got a cataract that needs doing, I would generally combine that with some sort of intervention to the endothelium.
So how often do you feel you need to see your patients?
It's all about managing that patient expectation, reason for calling them back a bit sooner. I think a year, if it's mild, is absolutely fine. When it becomes to that severe stage, you're probably passing it on anyway to be seen, as long as you give the patient the right education as to what they need to look for, should they need to come back sooner.
Have you got any tips for assessing Fuchs in practice?
I was going to say, enjoy the slit lamp. It can show you beautiful pathology. Just use that slit lamp.
And actually, we all have cameras attached to slit lamps now. Even the most basic cameras, the most advanced cameras. Picture it, just picture it, because it helps explain to the patient as well what you're seeing and what you're monitoring.
From a patient education perspective, I think at those, let's say we're the first people to kind of pick it up. I think it's just reassurance and just say, you've got it. This takes time to change. We'll be monitoring you. If you have any issues, you come back and see us. We know that people with a little bit of Guttata, a bit of Fuchs are not going blind, right? We know that that when there is intervention needed, whether it is just a hairdryer, a cold hairdryer in the morning, or sodium chloride drops, that is something that is readily available. I think if you can reassure the patient, then I think that's big. Because that's a lot of the time patients just want reassurance, right? Okay, I've got it, fine.
Maybe what we're saying is to other optometrists that they shouldn't panic if they see one or two guttata, they see one or two things. In a world of asymptomatic patient, we shouldn't cause alarm, but just be confident they've observed something.
How do you make sure you aren't missing mild Fuchs during a routine examination?
The real question is, does it matter? If it's mild, patient is asymptomatic, right? And you think you've done a good scan, and where does mild start? That, one bit of dropout. Mohammed, where does mild start?
I would say for me, if there's one or two guttata, I don't even know if I'll call it Fuchs at that stage. But if there's a few, for me, we have access to a specular microscope, so I'll do a specular microscope. If there's clear dropout on it, I would call it Fuchs. If you're not even sure if it's mild Fuchs, then it's probably a bit too mild to be of any major sick concern.
What role do you think optometrists can and should play in the long-term care of a patient with Fuchs?
I'm a massive believer in optometrists. We've got all the right tools in community, so we are definitely well equipped to monitor even pre and post grafts or treatment these patients up until a point where we think they need surgical intervention.
And even things like sort of intervening with basic management techniques like drops or bandage contact lenses or even scleral contact lenses. We're all equipped to be able to do these things and provide relief for the patients or solutions for the patients if they're not keen on surgery and intervention.
The one thing I would add to that is the problem with all of this is who pays for it. What can't be expected is for optometrists to take this into the community, and it sort of inadvertently gets bolted on to a GOS eye exam.
The reverse is also true, though, when it comes to post-op care. Who's going to check these graft patients' pressures and monitor other changes that could be happening?
Moving on to referral, how do you manage conversations with the patient about surgery?
I think you have to read the patient quite well. Some patients want all the information you can impart to them and they want to soak it all in there and then. Other people need a moment just to catch their breath, get the diagnosis under their belt, and then understand long-term implications.
It's like when a patient has a really early trace cataract and you've seen it and you've noted it, and how much people say cataract and they go, I've got a cataract.
I try and make it as light-hearted as possible because we know that in those early stages, it is what it is.
In our day and age now with ChatGPT and all the other AI devices that are out there that patients can easily just use Google. If it's even worse now because they use ChatGPT as well as Google. But I think it's nice to sow a few seeds just so that then they're not going down a rabbit hole.
As soon as you mention the word graft or transplant, to patients, it's such a lot. Those two words, it's really scary.
I do think, though, that highlighting environmental factors and sort of giving them a bit of, not homework to do, but giving them a bit of food for thought to take home and sort of understand the condition that, they could be making things worse by smoking or by excessive alcohol drinking or all these kind of things that people take sort of as sometimes a pinch of salt when you advise them in a testing room. I think bringing it back to this condition and telling them that you could be exacerbating symptoms or making, the cell count go down quicker can help sort of give them a little bit of stuff to do.
How do you balance watch and wait monitoring with deciding it's time to involve a specialist?
The one thing patients are very quick, in my experience, is if they feel their vision has changed, they will come and see us. If I think someone's getting close to driving standards, I will preempt it.
That's an important point, Kara, because if you're referring to an NHS department and I don't know how long the waiting list for, let's say, a DMEC or a DSEC is on the NHS, and they're already reaching driving standard, and then the ophthalmologist says to them, actually, you're not safe to drive, but you're going to have to wait a year for this transplant now. That's potentially a year of someone's independence you're taking away from them where they can't drive.
It really depends which part of the country they're in. I know some places it will be anywhere from 1 to 3 years. I would say generally for a DMEC, for me, it's probably 2 to 3 months. So it's not that long. You have access to 3 tissue banks from NHSBT to Italy and the US. So that's not always the case depending on whereabouts in the country you are.
What's a private wait, Puri?
not long, we get our tissue from America, so you can have it done within a few weeks, really.
Do you feel your referral pathways for Fuchs are clear and timely? Or are there barriers in the current system?
Is there a referral pathway for Fuchs specifically, or is it you just send it to the cornea clinic?
There's definitely not a local one.
Look up the CMGs, which I did on this condition recently. It's very unclear, actually. They talk about 3 different classification systems. There's no sort of, this all might be changing, though, because of modern technology. So, it's a grey area.
I think just there's no set visual standard, is there? Unless you're driving. It's easy. If someone's driving, boom, they know that they can't drive anymore because of this. You need to do something. If they're not driving, then what do you write? This patient can't see very well.
But our guidelines don't even say anything about vision. It doesn't even mention the word vision.
What is your top tip for making the right referral at the right time?
Send to a cornea clinic. Specify if you think that patient needs referral, that you would like a cornea consultant.
Be led by the patient and by a clinical judgment. So that conversation, that history and symptoms, we know our patients the best, right? They come and see us. We have that relationship with them. Be led by what they're saying to you. And if they feel that they're struggling, their vision is dropping, then make that referral with a heavy letter if you need it, even if their vision doesn't meet the so-called requirements, whether that be vision, driving standards, whatever consultant might feel under the NHS guidelines, but refer as you feel necessary.
Yeah, don't be afraid to refer and be specific in your referral letter to who you want your referral to go to.
There is a new treatment being offered in some hospitals. Mohammed, would you be willing to explain this to us?
At the moment, the most common way that we treat Fuchs dystrophy that has decompensated is usually in the form of an endothelial transplant, whether that be a DMEC or a DSEC. This is usually for people who are more advanced. Now, the treatment, as you may have heard of already, is the rho kinase inhibitor combined with just removing the decimase membrane. The thought is that it increases endothelial migration and proliferation, and therefore leading to corneal recovery. So essentially you are stimulating patients' own regenerative potential rather than putting in donor tissue. If it becomes well established, then you could intervene early. We could avoid doing a transplant and then do a relatively smaller, quicker, less invasive procedure, not do a transplant, and hopefully they retain more of their own endothelium long term. So there's less likelihood of rejection, less likelihood of graft failure. And then if someone fails, they can always end up having a corneal transplant anyway. From an optometrist point of view, what would you look for? I would say early Fuchs with good peripheral endothelium, so relatively central guitar tab and not much in the periphery. Patients who notice blurring in the morning that clears or have a bit of glare reduced contrast sensitivity. But there's overall vision generally still good. And patients who are motivated for intervention and understand the recovery can take a long period of time. Having said all that, I would say there is a wide variation amongst corneal specialists about doing this. At the moment, most people in the UK, I would say, still go to an endothelial keratoplasty. But some people may start to do just central, we call it DSO, decimase stripping only, where we just remove the central decimase and we don't give anything else. So that's been done already for some people. But adding in the ROC inhibitor may help the recovery. In Liverpool, we generally haven't done that much DSO at the moment. One of the main reasons is that it's quite difficult to get hold of the rho kinase inhibitor at the moment, which might be partly why we're not doing this more often. But as that improves, it could change our approach, especially for the mild early cases.
It's not the same one as the glaucoma one.
It's the same one.
So you couldn't off-label it.
At the moment, it's proving difficult to get hold of just the rho kinase inhibitor.
Can I ask what the long-term studies are?
No, there's no long-term studies. There are studies on a few cases. There is a randomized controlled trial, multi-center around multiple countries. I think about that is ongoing to try and establish beyond doubt if it is beneficial.
And this is the ROC inhibitors being administered at the time of surgery as opposed to longer-term drop therapy.
No, so it's drop therapy after. So say they use it 4 times a day for 3 months after surgery, and then they stop.
Generally, the lifetime of a DMEC, though, is pretty good, Mohammed, right?
Generally, yes, but sometimes they fail in 5 years.
What's the percentage of failure in 5 years? Do you know? Because I guess that has a long impact. If we know DMECs are outgrowing the patients themselves, then is there any need to have intervention and then need a DMEC? If Charles said he's only given them a couple of years, what are we gaining?
Even if we can give them a couple of years, it's probably worth giving them that, because the thing with DMEX is that it is an unpredictable operation. Sometimes they do fail sooner than later. Sometimes there's detachments. And you can combine this with cataract surgery as well, by the way. You could take the cataract at the same time and just do this and not do the DMEC. That might save them from having one for the rest of their lifetime.
If I'm not referring for a DMEC just yet, are you suggesting now I should refer because we want to intervene earlier?
It would really depend on the patient. If the patient is symptomatic, for example, and they haven't got a cataract, and they're really motivated to have something done, and they fit the criteria of just central guttata with a healthy peripheral endothelium, I would say there is a very small subset of patients that have all of those things. They have to tick all of those boxes, and obviously we'll always say to them that you may need a DMEC or a graft going forward. How long it will be before that's required, we don't know.
I think anything that stops a more complicated intervention is always good for the patient. You know, if you can find your unicorn and you can get away with just the central clearing, and then just with the use of rokinase to get that proliferation of cells, that sounds like a great option.
You reduce that need to try and find those grafts and save those grafts for the patients that really do need it.